So I had a question. So Dr. Wolf, can you describe the term smoldering in relation to MS? And so what I would say is that is not, okay, is it on now? Working? Okay. All right, so what I would describe as smoldering in relation to MS is that we think about inflammation in different buckets. So we think about acute inflammatory events with things like relapses. And then we can also think about more of innate immune system resident in the brain, sort of driving like a lower level of long-term inflammation that does not result in these acute relapses to happen. And we think of that as being a major driver, probably of progressive MS. So from things not just of lymphocytes, but also immune cells like microglia. So when we use smoldering as sort of a representation just of that longer term inflammation that is probably hiding out behind the blood-brain barrier as opposed to coming in from the blood like the rest of the inflammation driving relapses in MS.
Okay, so I have a question. Mark Cuban's pharmacy gives teriflunomide for $14. Is this regulated by the FDA and safe? Yes, I believe it is regulated by the FDA. Mark Cuban's pharmacy, Cost Plus Drugs. It's an online pharmacy that we've been using quite a bit for generic drugs, including ones that, you know, for certain disease modifying therapies that are now generic. And yeah, I mean, certainly if the alternative is to be spending like a ton of money out of pocket, that seems to be a good alternative for dalfampridine as well. I was just reminded out there. And so yes, do bring that up or just talk to your provider too if you're having difficulty affording the medications that are being prescribed, because there may be options like this available.
Yeah, and I'll just mention a couple other drugs. So Mark Cuban online pharmacy, Cost Plus Drugs. Other things that are often cheaper on there include generic dimethyl fumarate. So for anyone who's on Tecfidera, that is often much cheaper than what people pay through their insurance, as well as some of the erectile dysfunction medications are common for a lot of our patients. Those are also much less expensive, frequently through Mark Cuban. So just something to take a look at. Then we had a question, is there any link between multiple sclerosis and head trauma? So I would say not conclusively. There are several epidemiological studies that have tried to answer this question, and it appears that there is either not a risk, or if there is a risk, it is very slight increased incidence of MS in patients with higher head trauma.
Okay, I have, if no change in lesions, what other ways are there to measure changes in MS and decisions to change, reduce, discontinue DMTs? Yeah, great question. And this is kind of goes back to Dr. Corboy's talk, where frequently as the disease goes on, we see less and less in terms of new MS lesions on MRIs. And that's especially the case when people are being, you know, treated with very effective medications. And so how do you make those decisions? Well, it's difficult. Well, one thing we do know is that in people who have had recent MRI activity, those are probably not the people that you would want to start making de-escalation or discontinuation decisions on. And you know, how recent is recent? Well, I mean, you saw some slides there in terms of, you know, Dr. Corboy's study, which used 3 years at least for the MRI of no new lesions, and then, you know, 2 years I think in the .ms trial were used. So, you know, the longer the better. The longer that your disease has been stable, the more likely you're gonna remain stable if the treatment is de-escalated or discontinued. But yeah, there are a number of factors that come into play. You know, how old you are, how long the disease has been that you've had it, how long the disease has been stable. Or at least not in terms of no recent relapses or MRI activity, and what treatment you're on as well makes a difference.
Next question I have is there a concern with administration of contrast with MRI causing heavy metals toxicity in patients over their lifetime? And I would say not really, but we do know that gadolinium contrast agents can accumulate a little bit inside of the brain. That has not been demonstrated to have any sort of adverse event, but is one reason to think about not constantly using contrast as part of MRI evaluations.
And I'll just add that the contrast used in MRIs are chemically very different from the contrast used in CAT scans and other types of radiologic things. So if you've had a bad experience with like a CAT scan contrast, for instance, it has no bearing on your getting contrast for an MRI. This one looks like is a frexalimab question. I have, what provider or office can provide Botox injections? Is someone at Rocky Mountain MS Center doing this? Great question, and I meant to bring this up in my talk. Right now, we're usually sending folks for Botox to other neurologists who are specially trained in the procedure, especially folks who have a background or a subspecialty in movement disorders like Parkinson's disease. They tend to do a lot, or rehab specialists, physiatrists will also do Botox injections for spasticity. One of our advanced practice providers, at least one of them, is also training to do it at our center as well. So hopefully that should be available to our patients, but it's not difficult for us to put in a referral for it.
Okay. This question is about TYAB or natalizumab. So it says, if I go beyond 28 days for my infusions, are there significant risks with being 7 or 8 days late in a given month? And the answer to that is no. So there's been a considerable amount of study actually doing extended dosing, so doing TYAB at 6-week intervals, and that appears to be both effective and safe. So there would not be an issue typically with being a little bit late if you're on a 4-week infusion schedule.
Yeah, most of the time the TYAB uptick in disease activity tends to happen beginning at around 3 months after your last infusion. Like if you're going to get it, that's most often that and beyond, like 3 to 6 month kind of intervals when we tend to see it most. So at 5-6 weeks, it should be fine. Let's see what else we got. How do you know what's the right oral antispasticity medication? And how do you know when to stop taking antispasticity meds? So great question. I didn't, touch on this specifically. I just mentioned that there were a lot of them available. And honestly, it's kind of dealer's choice. We tend to use a lot of baclofen, as kind of first line, but there are other places that will use other medications. I think baclofen is probably among I should check into these numbers, but I think it's probably among the most wide, if not the biggest prescription in this country for MS spasticity. But it's certainly not the only one. And if it seems like it's not working, or if there's a potential reason why you would want to avoid it, then those other trying a different one, potentially with a different a slightly different mechanism might make sense. Baclofen has kind of a shorter half-life than a lot of the other ones, and so often we'll have people take it like 3 times a day, sometimes 4 times a day, and so. For things like spasticity, like at nighttime, sometimes medications with longer half-lives can be more beneficial, things like tizanidine, something like that. And so you might mix and match a little bit in that sense. How do you know when to stop taking antispasticity meds? Well, there's no length of time after which it's like dangerous to do so. But, I guess, as I was kind of saying in the talk, if it seems like it's not working, or if you're developing intolerable side effects, that would be the time to kind of talk about it, coming off or reducing the dose or changing to a different one, kind of thing. But I mean, people can take these medicines for years, can and do.
So this next question is really interesting. So it says, with frexalimab being compared to a placebo, as opposed to a comparator therapy, do you believe this medication is useful in MS or just an expensive therapy with little benefit? So that is, it's going to be hard to answer, but I definitely love where the question's coming from. So, for relapsing disease, we have wonderful options that are often not super expensive. So in my opinion, unless frexalimab has a better safety profile, which we don't know about, it may not, have a good cost benefit in relapsing disease. For progressive disease, harder to say just because we have more limited options. We also don't know yet that it works. So if it does, it would really be our second drug that would sort of potentially have FDA approval in that category. And in that case, it may be potentially super beneficial just because it's a brand new mechanism. I don't know how much it would cost, should it ever work and be approved, but I'm sure it will be expensive, just like most of our new MS drugs are. But definitely a great question to always keep in mind that that sort of negotiation between cost and efficacy.
I'm hoping that because it's an anti-CD40, it'll be twice as good as our anti-CD20 because that's how it works, right? For spasticity, if it's intermittent, is that still related to MS? For example, they use wrist pulling towards arm or severe cramping in legs or foot that eventually releases. Yes, absolutely. Those are like spasms. So yes, I kind of alluded to that in the talk. You can have either a more kind of persistent situation, or it can be an intermittent thing. And either one, you might try. Some of these things that I talked about in terms of stretching, rehab, oral antispasmodic agents. Like it could potentially help with that as well, the intermittent stuff. But you try it and you see, does it actually decrease the frequency of those of that cramping or wrist pulling? Yeah.
Okay. This question says, what is the difference between relapse activity and new lesions on MRI that may not be considered a relapse? And then what is the difference between T2 lesions and contrast enhancing lesions? So T2 is basically just the physics of the MRI. So it's going to produce a signal where MS lesions are going to be really bright. So like bright white dots that you see. And then contrast enhancing lesions are actually based on what's called a T1 MRI is when we look at those. And that's when that IV contrast leaks out into the brain and also causes white spots. But they're sort of looked at on two different protocols. The difference, so T2 lesions in MS can sometimes fluctuate over time, but usually once you have a T2 lesion, which we think of all MS lesions are going to show up on T2 at some point, it's going to stay there. So you can think of it sort of as looking like a scar on the MRI as an example. Contrast enhancing lesions are thought to be acutely inflammatory. So when we get a new MS lesion, the vast majority of the time, it's going to have contrast enhancement that shows up on the MRI. That is typically not going to last for a super long time. So we think about contrast enhancing lesions showing up for somewhere between like 4 to out to maybe like 12 weeks, and then it should go away as the inflammation dies down. So just two different ways of looking at things. So T2 lesion sort of shows everything. T1 lesion looking at acutely inflamed areas. As far as the relapse activity versus lesions, so also a really interesting question, and part of relates a little bit to what Dr. Corboy was talking about as far as what defines a relapse. So a relapse is really thinking about new clinical symptoms that would suggest a new lesion from the MS. And an MRI lesion can certainly happen without causing symptoms. So if you have a very tiny lesion in a part of the brain that is not, critical, it may be very easy to have an MRI lesion without noticing any difference as the patient. And that is one reason why we are so always interested in following MRIs to make sure that there's not evidence of disease activity, because we don't want to miss a bunch of little spots that show up that people do not notice symptoms from.
You maybe go to the paper you got?
Oh, yeah, you can take that.
Okay, just don't want to ignore these. So I have, what resources are there for women with MS who are trying to conceive / start a family, either in terms of conception / pregnancy or being a disabled mother with MS, pros and cons of getting pregnant with MS and needing to go off all medications? So great question or questions. So obviously, MS, because it's 3 to 1 women to men. We do see a lot of women, particularly young women, and many people want to start families, and that's generally great and doable. We actually have a colleague, Dr. Anna Shaw, who has a particular interest in this area. What happens to people who want to get pregnant, deliver, and then with their babies and breastfeeding and whatnot, and how does that play with the medications that we use? It turns out that it's it's definitely, like I said, definitely doable, especially if we're talking about using our B cell therapies, our anti-B cell therapies. And we just need to come up with a plan of how to, ideally, assuming it's not like done by accident, but ideally you would try to, be off of the medication for, a little bit of time before conception took place, and then resume it shortly after giving birth. But Dr. Shaw is going to be aware of the resources available, all the latest studies. And so oftentimes, we'll arrange for like a one-time consultation with her to kind of go over everything with people at any stage really that are contemplating these questions. And sorry, I have a related, well, somewhat related, not really, just in the sense of involving women. Recommendations for women with MS in their late 40s / perimenopausal and MS symptoms getting worse. It's a big topic, and I would say that there have been some studies looking at whether menopause, changes or worsens MS symptoms. And I'd say things are kind of mixed. Some women have reported that their symptoms worsen around menopause, but some haven't. That's also around the time of life where, on average, we do start to see people, men and women, enter like the progressive phase, so like 40s and 50s, and so symptoms do get worse from that. Whether that has anything to do with the changes that are happening during menopause is still a little bit up in the air. I think there is another question out there about use of hormone therapies, and I think there have been studies looking at hormone replacement and using estrogen specifically. It was kind of not all that impressive results in terms of benefit. And so, it's not clear whether it's, the loss of estrogen, or if there's, some other hormone or some other factor that, is at play in those people who do experience worsening of symptoms around that time. But, I would say that certainly if going on HRT is being recommended for, to treat whatever perimenopausal symptoms you are having, then we usually are all for it. It's just not something that we'll generally recommend because it hasn't clearly been shown to make a difference in terms of the MS symptoms.
This question, so what kinds of infections are related to the use of rituximab over time? And then I had a related question, are there risks with continuing current rate of Ocrevus infusions versus the risks of infections and relapses? So when we think about infections from most of our therapies, but especially CD20 therapies, so Ocrevus, rituximab, Kesimpta, Briumvi, predominantly respiratory infections, urinary infections, and then to some extent some skin infections. So those, are thought to be dose and duration dependent from the standpoint that you can start to drop things like antibody levels in the blood as the longer you're on the drug. So that has been an idea to essentially, as Dr. Corboy had mentioned, to sort of de-escalate in a sense if a patient's doing well, to do the infusion less frequently, as that may reduce the exposure to the drug and reduce the infection risk. Those strategies, tend to look like they are very successful, where patients getting rituximab, for instance, if they've been stable, and are getting it once a year as opposed to every 6 months, they tend to look like they do quite well from a relapse standpoint. We do not know, though, like how patients who are progressive may do in that context, and there's just not enough studies that have been completed evaluating that. We actually do not, as far as I'm aware, have amazing data that although it would make sense that giving you the drug, less frequently, we don't actually have not demonstrated prospectively that there actually are reduced infections for patients in that circumstance who have already been on drug for a few years. But I do think it makes sense, so especially for relapsing patients who have been stable, especially if there's a hint of getting frequent infections, to start to talk with your doctor about, maybe reducing how often you get the drug. I think that is a very reasonable thing to have on the radar. And there will be a few studies that are being completed specifically with rituximab that are in Sweden and Denmark, that we should have results from in the next 2 to 3 years that are exploring those in more detail.
Okay, I have a couple questions here on cannabis use for spasticity. Are there similar benefits with CBD-only products absent THC? And, is cannabis, are there certain types like sativa that are better against spasticity than indica? Have there been studies? These are good questions. And, the short answer is no, we need more studies. We really don't know much. There are a lot of different strains out there, a lot of different formulations that you could use, different ratios of, like, for instance, CBD to THC. THC is the component that tends to get people high, that, has that euphoria-inducing feeling, and THC doesn't have as much of that, but tends to be associated more with things like, relaxing the nerves. So for use in spasticity and use in like nerve pain and stuff like that. So, I'd say, we're not the experts as much as you guys are. We would love for there to be more trials looking at this kind of thing. It's just up till now has been somewhat difficult to do, just based on the way that it's, federal law. And so, I've talked to patients about using, different formulations of it, and, especially with folks where there's maybe a component of, like, cognitive issues or fatigue or something like that. The products that have the higher THC component might not be the best thing, because that might affect them more. And maybe just going with the ones that have more, like, CBD type things. But again, I think this is an area that we should really learn more through research if we can.
Okay. This question says, what causes painful neuropathy and how can it be treated? So we think of neuropathic pain in MS basically happening because there's been injury to sensory circuits in the brain, but especially the spinal cord. And then those circuits can essentially misfire, which leads to an aberrant response that then, produces that pain sensation. The good news is that there's lots of treatments for this, both from a pharmacological standpoint. So things like medications, so like gabapentin, being a favorite, duloxetine or Cymbalta, medicines that basically act on the nerves to reduce that abnormal firing pattern that produces that pain sensation. As well as things at times, depending on the cause of like psychology and others, pain therapies that are not just medications. There's a lot of ways to treat this and help it be more tolerable.
I have a couple of questions that I'm going to combine because they both are kind of medicine adjacent, but very important. One is, are there other resources to help navigate Social Security disability? And then another one is, how can we get insurance to provide more coverage for high efficacy treatment instead of moderate efficacy treatment? So for the first one, I would say, yes, we do have a wonderful resource person who's been connected to our center for several years, Tom Stewart. If you check out our desk right here, you can get the contact information for him. But he's helped a lot of our patients, navigate that issue and getting Social Security disability or other long-term disability. And so yeah, I would definitely use that. As far as the insurance goes, yeah, I mean, yes, that can insurance companies kind of get to set their own agendas, but we have people that we work with. We have a nurse navigator that kind of helps us and other folks. Talk to these people that are at the booths. The people from the drug companies, because they tell me that they're trying to get people approved and scheduled faster and that kind of thing. So if you have specific questions about your treatment, then they might if they're the company that's producing your drug, they might have some answers for you too. And I think we're down to 0 minutes. You want to take one more?
Are we down to 0? Okay. I'll answer these two really quickly. So can massage therapy help MS patients with spasticity? Yes, absolutely. And then how did COVID and long COVID impact MS, and can long COVID turn into MS? So we have not demonstrated a conclusive link between getting COVID and later developing MS or having MS relapse activity. We do know that for MS patients that were to get COVID, they would very frequently have pseudo relapses or these worsening of symptoms from the infection, but not have evidence of new damage to the nervous system. So similar to what would happen if you had the flu, for instance, or strep throat, or really any other infection.
Yeah. Yeah, we saw like very few like random inflammatory things happen, after infection or after a vaccination. But like just given the sheer number of people who were either vaccinated or got exposed to COVID up till now, I think we would have known if there was a if there was a huge increase in MS incidence, for instance, unless it's, 15 years later, but I think that's going to be unlikely. Yeah. All right, good. Well, thank you for your attendance.